Good morning, everyone. I say hi, you say. Good retention. Okay, so we're going to be presenting here section N. Waiting for it to come up on the board here. There it is. Okay. N was for new, but it's really medications. So here we go. So you now have additional acronyms that you will be adding to your list. They are all listed in that single sheet that was directed for your viewing in your folder. And some of these you're familiar with, such as CMS, Centers for Medicare and Medicaid Services. And then newer one is the Drug Regimen Review, DRR, which was developed because of the IMPACT Act, which stands for Improving Medicare Post-Acute Care Transformation Act. And INR, we'll be talking about that in one of our examples. That's the International Normalized Ratio. Of course, you're familiar with LTCH and the LTCH CARE Data Set. Medication Administration Record, you're probably familiar with that one too, the MAR. And PAC, Post-Acute Care Quality Measure, QM, and of course, Registered Nurse. So let's look at what you'll be, we'll be reviewing here. Oops, sorry. First, we're going to define the new medication and section, medications, and we'll be explaining the intent of section N. We'll explain the new items that are now contained in the long-term care hospital continuity assessment record and evaluation. This is your version 4. We'll be discussing coding instructions and the needed information that are essential for you to code accurately these items. And we'll also be providing you with practice coding scenarios as well. So our objectives by the end of this presentation will be for you to be able to state the intent of section N, to describe the new DRR quality measure, and articulate the purpose of the new items, as well as all the different coding options. And most importantly, to apply those coding instructions accurately, and you'll be having that opportunity with the practice scenarios that we'll be going through. So the official name for this process quality measure is Drug Regimen Review Conducted with Follow-up for Identified Issues. So this process measures data is currently being collected by home health agencies since the beginning of this calendar year. And you folks will begin to collect the data for this quality measure July 1st, 2018. So you're first out the door as far as the brick and mortar facilities, and next will be IRF and SNF, who will be collecting the data beginning in October. So this is an assessment-based cross-setting quality measure. It began with home health having medication reconciliation items within their measure, the OASIS. And about 3 years ago, CMS had RTI and APT collaborate in putting together this cross-setting version of the measure so that all could be used in a standardized cross-setting manner. And so we're very excited about being able to bring this to you after the years of developing the measure and getting so much input from providers like yourself. So it is contained in the assessment. It is a cross-setting quality measure, and it was adopted to meet the requirements of the IMPACT Act domain of medication reconciliation. And as stated, you folks will not begin to collect the data until July 1st of this 2018 coming year. So this measure assesses whether LTCH providers conducted a drug regimen review upon admission and if you were responsive to potential or actual clinically significant medication issues when such issues were identified upon admission and throughout the patient's stay. So we'll be getting to more details because that's a very important concept in terms of you folks understanding that the quality measure description is, here we go. The quality measure description is explained using the criteria in meeting the measure requirements. It's reported as a percentage of the specific patient population stays during a specific time. So for this process measure, a drug regimen review was conducted upon admission. The reports are, again, the percentage of patient stays in which a drug regimen review was conducted upon admission and clinicians completed all the actions recommended by a physician or a physician designee during a timely follow-up period, which in this case is by midnight of the next calendar day. So this follow-up, which was completed each time the potential or actual clinically significant medication issues were identified throughout the entire stay. So let's look at this from an equation perspective here with your numerator and your denominator. So when we're calculating the percentage of patients that successfully met the DRR measure criteria, we first have to set up this fraction. You can see we have the numerator on the top and the denominator on the bottom, and we'll be dividing the numerator's number by the denominator's number. So let's work our way from the bottom up. The denominator represents the number of patient stays in your LTCH during the LTCH specified reporting period, and that's your denominator number. The numerator represents the number of those patients who were in your denominator figure that met the following criteria. So the patients, the stays where, and this again is the numerator, the care provider conducted a drug regimen review upon admission, or the patient is not taking any medications. And each time potential or actual clinically significant medication issues were identified throughout the stay, the care provider communicated with that physician or physician designee and completed all prescribed and recommended actions by midnight of the next calendar day. So once you have established this numerator and denominator, the numerator is divided by the denominator, and that becomes the percentage of patients in your LTCH facility that met the criteria of this process measure. So for the DRR, this measure has no denominator exclusions. And this measure is not risk adjusted or stratified. So the LTCH CARE Data Set version 4 items included in the quality measure are the following 3 items. N2001 is the drug regimen review. N2003 is the medication follow-up, and we call the discharge item N2005 medication intervention. If a dash is entered for any of these 3 items, the patient stay will not be included in the numerator count. The patient stay will be included, however, in the denominator count. Let's go into this more thoroughly in our section N, medications. Again, it's a new section, so I know you folks are eager to find out as much as possible in terms of what this medication, this drug regimen review is about. So let's take a look at the first new item, N2001. So that is, did a complete drug regimen review identify potential clinically significant medication issues? And you will respond with 0, no, 1, yes, or 9, NA. We will go through each one of these responses very thoroughly. The second admission assessment item is N2003 medication follow-up, which asks, did the facility contact a physician or physician designee by midnight of the next calendar day and complete prescribed, recommended actions in response to the identified potential clinically significant medication issues? For that one, you'll answer either 0, no, or 1, yes. And for the discharge item, and again, this N2005 is to be added to the planned discharge, the unplanned discharge, or the expired assessment, again, effective July 1st, 2018. And it asks, did the facility contact and complete physician or physician designee prescribed recommended actions by midnight of the next calendar day each time a potential clinically significant medication issue was identified since admission? And by admission we mean upon admission all the way through the patient's stay. So that is a comprehensive item that looks at from admission, the point at admission to discharge. So this is a very important section about definitions, because this is where all of your questions, I'm sure, are brewing here. So what exactly is a drug regimen review? It's quite different than just a single medication reconciliation, and we want to make sure that you folks understand that concept in terms of its comprehensive nature. So the drug regimen review in post-acute care is generally considered to include medication reconciliation. That's what you're used to when a patient comes in to the door. But it also includes a review of all the medications a patient is currently using. And that is for the purpose to look at how that affects your patient. Will there be a drug interaction? Does that person have allergies? What are all the other considerations, not just comparing the medication lists, but then looking at it from a patient-centric perspective. So you're going to look at all the medications a patient is currently using and review the drug regimen to identify, if possibly, and possibly prevent potential clinically significant medication issues by following that grouping of tasks that this represents. Note that the drug regimen review includes the following: all medications prescribed and over the counter, including nutritional supplements, vitamins and herbals administered by any route. So you're going to be looking at all the different routes that patients receive medication, whether it's oral or topical, inhalant, injections, sublingual, parenteral, and by infusion. So the drug regimen review also looks at total parenteral nutrition, TPN, and oxygen as well. So what exactly is a potential clinically significant medication issue? It's a potential or existing issue that in the clinician's professional judgment warrants physician or physician designee communication and completion of prescribed medication, recommended actions by midnight of the next calendar day at the latest. So let's go over this a little bit more. So in part, it is your clinical judgment and knowledge of that patient and that patient's conditions that will help you to use and determine what exactly are potential clinically significant medication issues. Those issues that are so critical for you to communicate to a physician or a physician designee, that communication must take place and actionable steps must take place by midnight of the next calendar day. So there may be other issues that come up, but maybe not as severe and requiring this degree of action. So that is the distinction that you as a clinician, knowing your patient, must make in determining what we are speaking of when we're talking about potential clinically significant medication issues. So this is the part where you have to use that good clinical judgment and make that distinction, because those are the medication, the issues that we are talking about that are elevated to the point where we want to designate them as part of this measure. These require specific, timely communication with that physician. And at the latest, oftentimes this is something that's happening in your facility as soon as you find out, within hours of receiving a patient, right? So we say by midnight of the next calendar day. It may happen much sooner than that. Okay, so let's look at potential or actual clinically significant medication issues that may be included but are not limited to the following. So we've heard from you folks saying we want to know, what are some of these issues? Can you give us some examples? And so we're including some, but again, it's not an all-inclusive list. So some of the issues might be medications prescribed despite medication allergies that patient may have noted in the patient's record. It could be adverse reactions to medications. It could be ineffective drug therapy. It also could be drug interactions such as serious drug-to-drug or drug-to-food and drug disease types of interactions that you would have to know about. It could be duplicate therapy, such as a generic named drug brand that has an equivalent, and both have been prescribed. They've been co-prescribed. In addition to the list of these potential issues, but again, not limited to, it could be that you've got the wrong patient with the wrong drug, with the wrong dose, wrong route, and the wrong time that it was administered type of errors. It could be errors of omission, such as drugs missing from prescribed regimen. It could be non-adherence, such as things that may be purposeful or accidental as well. So remember, this is not a finite list of examples, and your facility may recognize other examples of what, in your clinical judgment, would require timely communication and remedy by midnight of the next calendar day. So we've included more examples for you in the brand new LTCH manual that you may have seen on CMS website. We've provided you a link right here on this slide that you can see and read through further examples that will help you through your decision making for section N. And please note, we want to recognize that some medication issues, as I stated earlier, may not require immediate attention. And these would not be considered potential clinically significant medication issues, even if they may be important ones, but not to the same degree where it needs this timely remedy and communication. So it's really your clinical judgment that's required in determining what issues should be communicated and remedied by midnight of the next calendar day. So what do we mean by contact or communication about potential clinical medication issues required? It's a two-way communication. So this two-way communication requires, first, that the communication needs to be made to the physician or the physician designee to inform him or her about what's happening in this case and about this potential or actual clinically significant medication issue. And then the second part of this communication is the response from the physician or physician designee to communicate what their recommendations are, what they are going to prescribe that you do, or what kinds of actions that they may want you to take to remedy these identified issues. It may be several steps, some of which they want you to take by midnight of the next calendar day, and some they may want you to take after that period of time. But those are their recommendations, and that it's your responsibility then to follow those recommendations that are made to be completed by midnight of the next calendar day, and then you would complete the others later. So there's different forms of communications in terms of how that information is communicated, and each facility might have its own methods in terms of communication. Your communications may be in person, they may be by telephone to the acute care provider who you had questions about in terms of information, voicemail, electronic means, facsimile, any other means that are appropriately conveys the message about the patient's status. That's the important part. And your communications will likely be documented, and that communication took place and what the remedy had been for that, those recommendations or actions that you were to take, and that they were in fact completed. So this will be important in coding your measure, is having this tracked. So method of communication can also be directly, communication to and from the physician or the physician designee, or it could be an indirect type of communication through the physician's office staff on behalf of the physician or the physician's designee, and in accordance with whatever the legal scope of practice is in terms of that communication. So let's look at the medication follow-up. So that's the third piece of communication, the actions to be taken in regard to the follow-up of the potential clinically significant medication issue. And this is to ensure that the recommended actions were taken as intended by the physician or physician designee in response to what you communicated as that potential or clinically significant medication issue. Okay, and let's look at next the coding guidance and the very important practice scenarios. So where do you go to find this information from which to code these three items? So first of all would be the medical record, and you may have electronic healthcare records, electronic medical record that you would be reviewing, and other forms such as paper medical records that were transferred with the patient to your facility from the acute care hospital or other facility. There might be the medication list, also known as medication administration record, the MAR, and also you may have a home medication list. And that's important too to consider in terms of what was your patient taking, what did they bring into your facility, and what are they continuing to take even though you're not administering that medication. Those are all important things to consider when a patient's information is taken in terms of their admission. So these also could be clinical communications in the notes, including pharmacies, information and nursing, physician designee, and other applicable clinical notes. So think about that when you're deciding upon what kind of action plan you're going to take, knowing that there's these disparate areas that this information may be found. Think about that in terms of actionable steps that you want to take in terms of bringing this to your facility and determining how you're going to approach this measure. Data sources also and resources may be found in the acute care hospital discharge summary and discharge instructions. You also may have discussions including with acute care hospitals and other staff and clinicians responsible for completing the drug regimen review. And of course, as I mentioned, the patient, or in some cases you may be talking to the patient's family or significant other in terms of medications that that person is on. So the purpose of these items that are contained in the admission assessment, two of which are in the admission assessment and one in the planned, unplanned, or expired discharge assessment, are the following in terms of each one of these items. We have the N2001. Again, this is where you identify if the drug regimen review is conducted. Remember, that's not just MedRec, that's also including all these other considerations of the patient's conditions. So it's, as one clinician called it, it's a MedRec on steroids. So you're really doing a comprehensive look at the patient. And you're going to find out if there was if you identified any potential or actually clinically significant medication issues. So that's what that one item looks at, that the DRR was conducted and whether or not there was a potential or clinically significant medication issue. Because if the answer is yes, then you do answer the next item. If the answer is no, and we'll get into that more in detail, then you would be skipping N2003. Again, we'll talk about that in detail. But what is N2003? That takes that identified issue and asks if the facility contacted a physician or the physician designee and completed all of those recommendations, all of those orders that that physician or the physician designee had communicated with you and your staff, and for the purpose of ensuring that that actionable step was taken to respond to all of, there's one, but there may be many, to those potential clinically significant medication issues. We know in the literature that this is an issue, and I see some heads nodding in terms of that these issues do come out, whether it's because of communication issues with the discharging facility, or if there was some miscommunication within your own facility. But the literature definitely shows that there are issues here, and that's why it's so important, and this being a process measure, that you folks do take this seriously. The discharge item, N2005, looks at the patient's entire stay. So it's looking at whether the potential clinically significant medication issue was identified upon admission, and it also looks at throughout the stay. And if every time that happened, if there was something identified, that there were communications made and that there were the recommended actions taken by midnight of the next calendar day. So that's a very comprehensive item. It considers, again, both the admission and through the entire stay. So earlier we read through the items, and now we can see that there's numeric response codes that you will choose from per assessment item, and we'll go over these responses more thoroughly in a moment. You can see that item N2001 has codes 0 and 9, as well as 0, it has 0, 1, and 9. But when you read each one of these, as we will, you'll note that if you chose no, there were no issues found during the review, you will skip to a designated item in the special treatment section for the admission assessment. If you say yes, there were issues that were found, then you will continue with N2003, and then 9, not applicable, is is only used in this item to mean patient is not taking any medications. How often does that happen in an LTAC? Probably not very often, right? But if that was the case, then you would also skip to the item in the special section. So what steps do you need to take in order to complete N2001 at admission? So when do you complete this one? You complete this one at the admission, upon admission. Go through your drug regimen review as close to or the actual time of admission. Again, this is so critical with your patients being quite ill that attention needs to be taken immediately to these issues. So as close to that time that they come in is when you want to conduct this medication drug regimen review. Again, the purpose is to detect any clinically or potential clinically significant medication issues. So your coding instructions that you will use in our clinical scenarios here coming up are the following. And it's very important when you're instructing your clinicians to understand the definitions behind each of these codes, because codes may differ from one item to the next, and that's why it's very important that they understand what each one means. So coding 0, no issues were found during the review, is only determined after a drug regimen review was conducted upon admission and no actual or potential clinically significant medication issues were identified. That's code 1, yes, would be issues were found during the review. And again, this is if during the drug regimen review, at admission or upon admission, the potential or actually clinically significant medication issues were identified. And then code 9, in this case, not applicable, means that the patient's not taking any medications. And that's only after you have completed this drug regimen review and you've thoroughly investigated your data sources, they've been reviewed, you've maybe talked with the patients or patient's relatives or significant others. There's no medications that this patient is on. That is the only time you would use for N2001 Code 9. So if you had discovered that there were medication issues, you would go to N2003. And we can see that the two responses for this one is no and yes. And we are going to go through these thoroughly in terms of what each of these mean. So after you've identified, let's look at the steps for N2003. So after you have identified one or more potential clinically significant medication issues, you'll go to item N2003 and you will determine if all of the necessary steps were taken for the follow-up in terms of this patient by doing what was asked in terms of this two-way communication between the clinician and the physician. Was it completed by midnight of the next calendar day, and that each and every one of the physician's orders, instructions, expectations for what care you would give to that patient after being communicated about this issue were prescribed, were those prescribed and recommended actions completed by this timely period, which is midnight of the next calendar day. So let's look in detail about each of the codes so that when you are going through these examples that you will be able to code them correctly, and of course for the importance of your quality measure. So code 0, we've got, so you code 0 no, or you code 1 yes, and code 0 no would be if all identified potential or actual clinically significant medication issues were not completed by midnight of the next calendar day. That's what no means in this item. Again, it's very important. Code 1, yes, is if the two-way communication and completion of the prescribed actions recommended by the physician occurred by midnight of the next calendar day after those issues had been identified. So the clinician, there's other examples that we can give you too as to why you would code 0 no for N2003. So one is that the clinician did not communicate all the identified, I'll start over. The clinician did not communicate all of the identified clinically significant medication issues to the physician or physician designee until after midnight of the next calendar day. Or another example might be that the clinician communicated all identified clinically significant medication issues to the physician or the physician designee by midnight of the next calendar day, but the clinician did not receive a response from the physician or physician designee to communicate those prescribed actions until after midnight of the next calendar day. Or a clinician did not complete all of the physician prescribed recommended actions for all of the identified. So you don't get credit for just doing one. You have to do all of them. And it has to be before midnight of the next calendar day. It can't be some were completed by midnight of the next calendar day and then others were completed after, unless that was the intention of the physician to prescribe that recommended action of doing some of them before and some of them after. That's the only case in which that happens. So as far as coding yes in this one, a two-way communication took place, and as I just mentioned, you could get credit in terms of saying yes if you were prescribed to do some elements of that action before midnight of the next calendar day, but others were prescribed to do it after. You did the ones before midnight of the next calendar day that were intended, and you completed all of that. Then you can say yes, as long as the physician had said those other actions, those other steps could be taken after midnight of the next calendar day. So that's an important one to note as well. So what about this last one? medication intervention, N2005, that we see on the discharge assessments that we named. At discharge, you'll complete N2005, and you'll code either 0 for no. Again, you have to know what we mean by no in this case. 1, yes, and NA is 9. Again, it's very important to know the details of that, which we will go through. So your steps for the assessment are to review the patient's medical record and record all available data sources in all of the available data sources and identify potentially clinically significant medication issues that were identified at admission and throughout the patient's stay. Again, upon admission, this is the one that's comprehensive, and throughout the stay up to discharge. And 2, determine if the following criteria were met for all potential and actual clinically significant medication issues that were identified upon admission or at any time throughout the patient's stay. And again, that's upon admission all the way through discharge. So two-way communication would have had taken place between the clinician and the physician or designee, and it had to have been completed by midnight of the next calendar day, and all physicians or physician designee. You may have several physicians that you're working with or designees. All of those prescribed and recommended actions were completed by midnight of the next calendar day. So those are the steps that you take. And N2005 includes all DRR information you collected and coded when the patient was admitted, and I can't stress that enough, through the patient's stay. Okay, so let's look at the particulars in coding for this item. Again, a very important teaching point, something that you might want to include in your action plan in terms of how are you going to distinguish each of these codes from each of the items in the set. Code 0, well, first, we talked about thoroughly instructing your staff, and then looking at the codes. 0, no is coded if all, this is where it's very important for you to understand, no for 2005 means no if all clinically significant medication issues upon admission or at any time throughout the patient's stay, admission through discharge, were not completed by midnight of the next calendar day. So that's what no means in this case. For code 1, yes, that is intended to mean if all clinically significant medication issues were identified upon admission or at any time throughout the patient's stay. Again, admission through discharge, and they were all completed by midnight of the next calendar day. Now in this case, code 9, not applicable, means if there were no potential clinically significant medication issues identified upon admission nor throughout the stay, or the patient wasn't taking any medications. So you see that there is a distinction here in terms of NA. So it's very important for you to understand and also for you to teach this in terms of your group. So some examples of this might be that admission or at any time during the stay, the patient did not, this would be an example for no. Why would you signal no here? So at admission or at any time during the stay, the clinicians did not communicate all the identified potential issues to the physician until after midnight. So that's pretty cut and dry, right? And then another reason you would say no for N2005 might be that at admission or any time during the patient's stay, the clinicians communicated to the physician or designee all identified potential or actual issues, but the physician did not respond until after midnight of the next calendar day. So how could you have taken those actionable steps if they had not done so? Also, another example would be at admission or any time during the patient's stay, the clinician did not complete all of the intended actionable steps that were prescribed by that physician for all of those identified potential or clinically significant medication issues by midnight of the next calendar day. So even if at admission there were no issues that were found or issues were identified and completed, if any time during the stay that there was one, then you would also be using the code no, because you did not meet the criteria for the measure. So what are some more examples in terms of coding? 1, yes. At admission and any time during the stay, the clinician communicate all identified clinically significant medication issues to the physician. That two-way communication worked. There was response. It was timely. You carried out what was necessary in terms of completing those orders by midnight of next calendar day. Another example might be at admission at any time throughout the patient's stay, the clinicians contacted the physician or physician designee regarding all the identified potential clinically significant medication issues, and the physician communicated that no actions were necessary regarding the reported issue. There might be times when the physician says, let's just wait a few days. That's the action that you take, is to wait, and you are in compliance. So if that happened either at admission or during the stay, and there were never any instances where you didn't comply with this measure, then you could say yes. Code 1. Okay, now it's time to practice, right? So does everyone have designated responders in terms of your clickers here? Because we'll be going through these coding scenarios where you can kind of talk amongst yourselves. You also might want to bring out one of your, if you've got the items set in front of you too, that's also helpful. So let's get started here. Everyone's got their clickers in hand? All right, so again, what we'll do is we'll go through the scenario. I'll have you think about it. You'll make a decision. We'll go through what the items, what the response codes selections are, so that you can look at those, and then you'll make your decision. So here we go. The admitting LTCH, so here's the scenario 1, slide 37. The admitting LTCH nurse reviewed and compared the acute care hospital discharge medication orders and the LTCH physician's admission medication orders for Mrs. W. The nurse interviewed Ms. W., who confirmed the medications she was taking for her current medical conditions. Upon the nurse's request, the pharmacist reviewed and approved the medication orders as appropriate for this patient. As a result of this collected and communicated information, the registered nurse determined that there were no identified potential or clinically significant medication issues. So this is for the first item, N2001, and so your choices in coding would be, after asking yourself, did a complete drug regimen review identify potential clinically significant medication issues? So you choose A. For 0, no issues were found during the review. B, 1, yes, issues were found during the review. Or C, 9, not applicable. Patient is not taking any medications, or enter a dash. So let's think about that. I'm going to give you some time. You can start polling now and determining what your answer would be. I see more are responding, so we'll give a few more seconds here to see how many responses we can look at here. Okay, excellent. 93% said A, and A is the answer. So some people said yes. So of that, so the 7% felt that there were some issues in there. So that's where it's really tricky. It seems like it'd be fairly straightforward, but it's fairly tricky. You have to really look at all what's considered in that, and we'll have more opportunities in terms of responding here. Okay, so the answer was no issues were found, and what was our rationale? Well, the admitting nurse reviewed and compared the patient's discharge medication records from the acute care hospital with the LTCH physician's admission medication orders. So there was some collaboration with the LTCH pharmacist, and they also interviewed the patient. The RN determined that there were no potential clinically significant medication issues. And that's where we arrived at that answer. Does that make sense? Okay. So let's try it again. And this again is going to be a single question we're going to pose in terms of the scenario. For scenario 2, and in this case, Mr. C was admitted to an LTCH after undergoing mitral valve replacement, cardiac surgery. The acute care hospital discharge information indicated that Mr. C had a mechanical mitral heart valve and was to continue receiving anticoagulant medication. While completing a review and comparison of the patient's discharge healthcare records from the acute care hospital with the LTCH physician's admission medication orders, an RN noted that the admitting physician ordered the patient's anticoagulation medication to be held if the international normalized ratio, the INR, was below 1.0. Now, the RN questioned the INR level listed on the admitting physician's order based on her LTCH's established INR therapeutic parameters of 2.0 to 3.0, which prompted the RN to call the physician immediately to address the issue. So let's take a look at what oops, I think that started. No. So how would you code this? And the question would be, did a complete drug regimen review identify potential clinically significant medication issues? And the answer choices are A, no, 0, no issues were found during the review. Is it B, 1, yes, the issues were found during the review? Or is it not applicable, 9? Patient is not taking any medications, or would you enter a dash? So let's let you poll that. People can think about that for a bit. Like we have just about everybody. So let's take a look what you said. 100%, excellent. Okay, so that was excellent listening in terms of what happened here. I think you get it in terms of in this scenario. And of course, the rationale here was that the admitting RN reviewed and compared the patient's discharge healthcare records from the acute care hospital with the LTCH physician's admission medication orders, and the RN identified a discrepancy between the physician's ordered INR level 1.0 for this patient with the LTCH's standard therapeutic range of 2 to 3. The 2.0 to 3.0. The RN considered this to be a potential clinically significant medication issue because the admitting LTCH physician's order was to hold the anticoagulation medication for an INR of 1.0, which is below the LTCH's established therapeutic INR parameters of 2.0 to 3.0, and this, of course, could have led to potential clotting issues. Okay. All right, so we look at the next practice scenario. This is going to be for the second item. So for this item, we're going to be answering N2001 and N2003. So think about that when I'm reading this to you so that you present an answer for N2001 and N2003. Mr. B was admitted to the LTCH with a history of pneumonia. The acute care facility medication record indicated that the patient was on a 7-day course of antibiotics and the patient had 3 remaining days of this treatment plan. The LTCH pharmacist reviewing the discharge records from the acute care facility and the LTCH admission medication orders noted that the patient had an order for an anticoagulant drug as well as the antibiotic. On the date of admission, the LTCH pharmacist contacted the LTCH physician caring for Mr. B and noted concern about the potential increase in the patient's INR with this combination of medications. This placed the patient at greater risk for bleeding. The LTCH physician provided orders for laboratory testing so that the patient's INR levels would be monitored over the next 3 days, starting that day. However, the clinician did not request the first INR laboratory test until after midnight of the next calendar day. So how would you code this one? Which is, first we're going to start with the N2001 question, where you will answer, did a complete drug regimen review identify potential clinically significant medication issues? So was there one identified? If no is the answer, you would say A. If yes is the answer, you would say B. And if NA, the patient wasn't taking any medications, you'd say C. So let's find out what the answer would be in terms of the first part of this scenario. Was there a medication issue? Like, we've got lots of people voting, and let's see what we said. 92% said yes, there was an issue. 8% said no, there was not an issue. Is that because, people were thinking it was the next item rather than this item? We're not sure. Let's see what happens. Let's take a look at yes is the answer, and let's take a look at the next item. How would you code N2003? This is the one that looks at whether or not the facility contacted the physician by midnight of the next calendar day and complete all of the prescribed recommended actions in response to the potential clinically significant medication issue. So in this case, you say no if they didn't, yes if they did, or enter a dash. Let's see what your answer is here. Okay. Wait for polling answers. And okay, I think we've got everybody there. So in this case, we have 74% that said no, and we have 26% that said yes. Let's take a look at where there might have been some confusion here. So coding should have been 1, yes, there were issues found during the review, because there were clearly issues that they talked about in terms of the INR issues. And then for N2003, no meant they did not do what this measure speaks of doing in terms of follow-up. And so the rationale here was that the LTCH staff did not complete, to the extent possible, the physician-prescribed actions related to the INR laboratory test until midnight of the next calendar day. So it was after midnight, and that's why we said no for N2003. So you can see that this is not a cut and dry type of issue. You have to really look at the issues and determine what it is that needs to be done and whether you're in compliance or not. Okay. Teachable moments for your staff. Okay, so N2003, let's look at this. This is the comprehensive one. So for this one, this is the second item on your assessment. So let's look at this one. Mrs. S. was admitted to an LTCH from an acute care hospital during the admitting nurse's review of the patient's acute care facility discharge records. It was noted that the patient had been prescribed metformin. However, admission labs indicated that the patient had a serum creatinine of 2.4, consistent with renal insufficiency. The LTCH admitting nurse contacted the LTCH physician to ask if this drug would be contraindicated with the patient's current serum creatinine level. 3 hours after the patient's admission to the LTCH physician designee provided orders to discontinue the metformin and to start the patient on a short-acting sulfonylurea for ongoing diabetes and management. So these medication changes were implemented within the hour. Okay, so let's take a look at how you would answer the first item. So was there an issue that was identified upon admission? You would say no, yes, or NA for this. Okay, so was there an identified issue? Was it potential clinically significant medication issue? See what your answers are here. Like we've got lots of answers in already, so, okay, 100%, excellent. Okay, got it, nailed it. And of course, this second one would be N2003, did the facility make that communication with the physician designee by midnight of the next calendar day and complete the prescribed medication actions that were identified? Was all of this completed? The communication and the actions, were they completed by midnight of the next calendar day? You would select no if that's not the case, and yes if it was the case, or enter a dash. Let's see what your answers are. Okay, 100%, excellent, okay. And so those were both yeses. So the physician communication occurred and the nurse completed all the prescribed actions by midnight of the next calendar day. And in this case, the medication had been ordered that was contraindicated, right? Very important to have noted that for the patient's current condition. This is really good nursing in terms of that identification. And the LTCH clinician's two-way communication resulted in discontinuing that contraindicated medication. So this is what it's all about, and replacing it with the appropriate medication. It was done before midnight of next calendar day. All right, so this is now the discharge item. So for this item, we will be going through a scenario that looks at, upon admission, patient coming in to the facility, all the way through their discharge. So this one's a comprehensive one. We'll be answering 3 questions for this one. And so let's go through this and then determine what it is that we need to note. So we'll be asking again, N2001, N2003, and 2005. So here we go. At discharge from the LTCH, the discharging licensed clinician reviewed Mrs. T's medical records, which included admission through her entire stay at the LTCH, and noted that a clinically significant medication issue was documented during the admission assessment. At admission, Mrs. T was taking 2 antibiotics. An antibiotic prescribed during a recent acute care hospital stay that the LTCH physician had included in her LTCH medication orders, and a second antibiotic prescribed by the LTCH physician upon admission. That is toxic to the patient's kidneys due to the patient's renal disease. So, Ms. T's medical records further indicated that an LTCH nurse had attempted to contact the assigned LTCH physician several times about this clinically significant medication issue. After midnight of the second calendar day, the LTCH physician communicated to the nurse via telephone order to administer a newly prescribed antibiotic in addition to the previously prescribed antibiotic. The nurse implemented the physician's orders. Upon further review of Mrs. T's medical records throughout that patient's stay, the nurse determined that no additional clinically significant medication issues had been recorded throughout the remainder of Mrs. T's stay. So again, we're going to look at each one of the item sets to answer. So the first one on admission, so looking at admission, how would this have been, the scenario, how would it have been answered for N2001? Did a complete drug regimen review at admission identify potential clinically significant medication issues? No. Yes. No, meaning no issues were found during admissions review. Yes, issues were found during the admissions review. NA, patients not taking any medications. Okay, let's find out what you say about that. Okay, looks like we've got everybody's answer. 100%. Excellent. Nailed it. And that's, let's go to the second one, because if you find that there's an issue, you go to N2003. So in this case, did the facility contact a physician or designee by midnight of the next calendar day and complete all the prescribed recommended actions in response to that identified issue? 0 for no, you did not do that, or 1, yes, they did have that communication and did do the follow-up and complete it. Let's see what you said for that one. Okay, 96%. Okay, so 4% did not feel that that they weren't in compliance. So let's take a look at this. And then how would you code N2005 on the discharge assessment? So again, this is, in retrospect, you're looking at through the entire stay, did the facility contact and complete a physician or designee to prescribe recommended actions by midnight of the next calendar day? Each time, remember, we're including admission, so it's each time, admission throughout the stay, were those potential clinically significant medication issues identified since admission? Okay, how would you answer that? 0, no. 1, yes. Or NA 5. Take a look. Just about everybody answered. Okay, 84% said A, 16% said B. What's the answer? It is no. And why is this? Let's look at our rationale here. So for coding these items for N2001, it should have been yes, issues were found. In N2003, the answer should have been no. This was not completed in the timely manner that it was expected to be. And N2005, again, we had to say no. So the rationale is coding of this assessment items includes all clinically significant medication issues identified at admission or any time throughout the patient's stay that were not communicated to the physician designee within the prescribed recommended actions completed by midnight of the next calendar day. In this scenario, although no potential or actual clinically significant medication issues were identified by the nurse during the remainder of the stay, notification of the medication issues identified at admission, despite repeated communication attempts by the nurse, was not addressed by the physician designee. It was after midnight of the next calendar day that happened. Okay? So let's go through, let's see. Okay. Let's go through. We've got 5 minutes. This one, and see what we get. Okay, for this one, I'm going to have you do just N2005. So you'll be looking at all of this, but you'll be deciding what you would do at the end, okay? So at discharge, the licensed clinician completing a review of Mrs. K's medical record identified and noted 2 clinically significant medication issues during the medication stay. The patient's record included an order to hold the medication Mrs. K had received for deep vein thrombosis prophylaxis, and based on the patient's clinical status, the LTCH-RN determined that the physician needed urgent notification. The day after the observed symptoms were identified, the physician notification occurred. The LTCH physician provided an order to resume the medication, which was carried out by the nursing staff within the hour. In addition, a licensed clinician identified a clinically significant medication issue during the admission assessment period and contacted the physician on the same day. Both medication issues identified during the patient's stay were communicated and addressed by midnight of the next calendar day. And there were no additional clinically significant medication issues identified through the rest of the LTCH stay. So I'm going to go through the answers for... Okay, so let's look at 5. So this is in retrospect. This is at discharge. You're looking through what we just went through. So upon discharge, when you're looking at this comprehensively, did the facility contact and complete the physician or physician designee prescribed recommended actions by midnight of the next calendar day each time potential clinically significant medication issues were identified since admission? 0, no. 1, yes, they did every time, and in the timely manner, and NA. So what would you say for this? Okay. 92%. Pretty good. Okay, so let's take a look. In this case, we found that they had done due diligence all the way through the patient's stay. They met they met each of the steps that were required through this. Even though there was a medication error that was identified at admission, it was resolved by midnight of the next calendar day. So they got a yes for 2001, and they in 2003. So during the patient's stay, additional clinical medication issues were identified, but each time they were met, and that's oftentimes what happens in this. So let's take a look at the summary here. You've got a new section N with these 3 items that we've gone through. This measure assesses whether LTCH providers conducts a drug regimen review upon admission and were responsive to potential or actual clinically significant medication issues when such issues were identified upon admission and throughout the stay. So your action plan is going to be very important here, because as you can see, not everybody was 100%, and we went through this in 75 minutes. So, and you folks are charged with going through this educational process with your clinicians. So it's going to be really important that you provide them with lots of opportunities to get to know these items and the coding for them. So you would want to review the intent of the measure and steps for the assessment and all of the evaluation tips, and also you would want to refer to Section N in your LTCH manual in order to go through some more scenarios and also get more examples to be very familiar with that. So, and you might want to also think about and develop strategies for collecting this data. So how are you doing this? In our pilot study, when we talked to providers, we had some very interesting feedback from them. Some of them wanted to collect the data using a low-tech method, such as an Excel spreadsheet. Everybody would go to that spreadsheet. Everyone would know what happened in terms of this patient, in terms of these measures. There's many solutions out there. We don't prescribe any one in particular, but it's up to your facility to make that decision, to talk about it, to contact each one of the players here and make sure those communications are known and what this measure is about, so that they are responsible and responsive to giving you that information so you can collect that data, have it ready, have it there for everyone to view, to easily access in terms of coding this measure. So I thank you very much for your great care that you provide in LTCH. I know you have very sick patients, and we're just amazed at the great care that you folks provide, and we hope this helps you to add to your quality programs. Thank you.